Okay, I think we're ready to get started. Good afternoon, ladies and gentlemen. Thank you all for joining us for today's webinar on the topic of forensic neuropsychology in traumatic brain injury lawsuits. My name is Michael Morgenstern, and I'm the head of marketing at the Expert Institute. Today we are joined by Dr. James Walker, a double board certified forensic neuropsychologist with over 25 years of experience in both academic and clinical roles. Dr. Walker works with individuals with traumatic brain injuries and mental illness. He has testified nearly 200 times in civil and criminal trials. Dr. Walker currently practices in Nashville, Tennessee as a neuropsychologist at Clarity Professional Evaluation Center. Today's webinar will run about 50 minutes and will be followed by a 10-minute Q&A. You can type your questions into the question window on your control panel, and Dr. Walker will answer you verbally. Thank you all again for attending, and without further delay, please welcome Dr. James Walker.
Hi, everyone. Welcome to the talk this afternoon. I appreciate everyone being able to join us here. I'm having a little technical difficulties getting my software going. Let me see if I can correct this. I might just have to turn my webcam off. There we go. So let me talk a bit about myself just briefly. I do have a history of working a lot with folks who have traumatic brain injuries. My background, after I graduated from internship here at Vanderbilt Medical School, was to work with individuals in a brain injury rehabilitation hospital. I spent 2 years there as the neuropsychologist for a brain injury rehab facility. And during the course of that time, I was able to follow traumatic brain injury patients from the emergency room right on back to their return to home and work through the rehabilitation process. After that, I joined the staff at North Texas State Hospital, which is Texas's maximum security forensic facility, which is where they send all the worst of the worst criminals in Texas for evaluation after being referred by a court or being suspected of some kind of mental incompetence. I was there for 2 years as their neuropsychologist, and then I rejoined the faculty at Vanderbilt University School of Medicine, where I was employed for 12 years in the Forensic Services Division. In the course of that time, I had opportunities to work with lots of attorneys on lots of various cases involving traumatic brain injury as well as other serious mental conditions that affect people's behavior. I saw a number of individuals who were charged with serious crimes, individuals suing one another regarding various personal injury issues, late life disability cases, many different disorders affecting the human brain. About 4 years ago, I went into private practice, and I'm now the manager and director of Clarity Professional Evaluation Center, which is an evaluation center where we evaluate impaired professionals or professionals suspected of impairment of some kind, and we determine whether or not they're fit for duty and send them back to work. I also maintain a busy private practice in the area of neuropsychology. Let's see. Let's talk a little bit about exactly what neuropsychology is. Neuropsychology is the study of human behavior as it relates to brain dysfunction and disease. So the neuropsychologist is interested in individuals who've had some kind of damage or dysfunction going on in the human brain. We do testing to assess that dysfunction and try to come to some conclusions about what the progression of the person's disease is likely to be, what level they're functioning at, what kind of problems they're likely to have in the future. The neuropsychologist himself or herself is a clinical psychologist who has specialized experience and learning in the area of brain dysfunction. So, for example, during the course of my training, I had to go through the same neurological test courses that medical students go through in medical school. I had to do an internship related to people with Alzheimer's disease, traumatic brain injuries, and other disorders that affect the human brain. Now, it's important for you to recognize especially as you think about retaining an expert, that in most states in the country there's no licensing control on which psychologists can refer to themselves as neuropsychologists. So if you're a psychologist and you have a license to be a psychologist, there's really nothing that can prevent you from describing yourself as a neuropsychologist. This is something to be aware of, because there are many psychologists out there who do describe themselves as neuropsychologists who do neuropsychological testing of some kind or another, but they really don't have a lot of credentials in the area of neuropsychology itself. The best way to establish whether or not your psychologist is really a neuropsychologist and really has the background and experience necessary for serving as a neuropsychologist is board certification by the American Board of Professional Psychology. Several years ago, the American Board of Clinical Neuropsychology joined up with the ABPP board, and now that joint board is the best way to determine, if a person has certification with that board, the best way to determine if your expert really is a qualified neuropsychologist. Let me talk a little bit about choosing an expert in the field of neuropsychology. You should consider choosing an expert who is thoroughly immersed in treating and assessing the disorder that you have interest in. The neuropsychologist is certainly, most neuropsychologists are trained in working with individuals with Alzheimer's, stroke, traumatic brain injury, and so forth, but it's very important to have a neuropsychologist who has specific experience in the exact disorder that you're interested in. So, for example, if you have a patient who has a traumatic brain injury or suspected thereof, you need to choose a neuropsychologist who has literally followed traumatic brain injury patients throughout the course of their treatment. The same is true if it's multiple sclerosis or epilepsy or Alzheimer's disease. You need to choose a psychologist who has experience in that particular disorder. Just like if you went to a surgeon, if you injured your hand, you wouldn't want to go to any old orthopedic surgeon. You'd want to choose a surgeon who has experience in treating disorders of the hand and who actually has operated on lots of people who have disorders of the hand. You ought to choose a expert who has an academic background. You know, there's no substitute, in my opinion, for professionals to have to actually work with students and teach students in doing what they do. In the course of a medical center type training or university background, the psychologist meets with patients, with students present, and actually goes and assesses and treats patients with students present and has an opportunity to teach the students what they're doing. That's really critical because the teaching aspect is so important. You want someone who in the courtroom and testifying is capable of teaching the jury and explaining to the jury what the various issues are involved. And you want someone who's focused on the educational process. Let me also suggest that you want to choose an expert who is not only just unbiased and fair, but also who cares about the outcome. You know, I tell people that a lot of my job is giving attorneys bad news, and I'm afraid I often have to share contrary opinions when I need to assess a patient, and I have to give bad news about what my opinions are. And that's just part of being unbiased and fair. It's very important for the expert to not be swayed or be biased in any fashion. But you do want an expert who cares about the outcome of the case. You want an expert who cares about whether or not his or her opinion is being communicated effectively and whether or not individuals are being persuaded by the opinion. Because when I see a patient, I come to a conclusion. I do have a vested interest in helping people understand the reasons for my conclusion and why I'm concluding what I have. You should also choose an expert who's published on the disorder in question. You know, the peer review process is critical when it comes to honing an individual's skills and making sure that your expert is up to speed on the research related to the disorder. In this field, every month there are developments in the human brain and how to assess human brain functioning, and you really want someone who stays up to date on the literature. You should also choose an expert who's experienced with serious pathology. You know, many psychologists go into practice And they go there, make their way through graduate school, they go into private practice perhaps doing counseling or doing psychotherapy, and really never meet an individual who has schizophrenia or Alzheimer's disease or serious diseases that affect human brain functioning. You want someone who has worked extensively with individuals who have really serious disorders. And of course, you all know that you need to choose an expert who has a track record of testifying for either side. In the course of my practice, I'm contacted on a weekly basis by attorneys both for the plaintiff and defense, and have testified a lot for both sides. You want to choose someone who has had an opportunity to do that and who makes it a practice to do that. You also need to choose someone who can translate clinical jargon into everyday English. You know, you don't want your expert to share information like this patient has significant challenges in their gamma-aminobutyric acid system. You know, you want an expert who instead is going to say, because of his brain injury, this gentleman has much slower thinking because of chemical changes in his brain. You want someone who is going to be able to interpret and translate information to where everyone can understand them. And of course, you want someone who's going to take the time to learn the legal issues involved. Here in Tennessee, we have certain standards related to personal injury cases. I'm sure every state's the same. And it's important for the expert to be aware of what the specific questions are that are being asked. And it's also important, I think, for the expert to be thoroughly prepared. Before I go into a deposition or into a courtroom, I will have read everything available to me on the case, every piece of paper, every medical record, every prior deposition that's provided to me. I have an opportunity to go over that and prepared to answer questions. You ought to choose an expert who is prepared to do that and who also wants to meet with you and go over planned testimony, proposed questions, who's willing to spend the time with you necessary to explain the reasons for the conclusions and opinions that have been offered. I would also suggest you need to choose an expert who's pretty savvy, who's very careful about being misled or manipulated. You know, in the course of doing this kind of work, the expert has an opportunity to deal with lots of competing agendas. The patient has an agenda. The defense attorney has an agenda. The plaintiff's attorney has an agenda. And it's very important for the expert to, as best as he or she can, stay above the fray and avoid being misled, evaluate information for accuracy, and make conclusions based upon the totality of the data. And I would also suggest you want an expert who takes nothing personally in the course of doing expert work. You know, I recognize that in the course of testimony and consulting with attorneys, lots of things are going on in terms of zealously advocating for your client that may not be apparent to the expert or to other people. But I know at this point that emotional displays during courses of deposition or dragging up negative information about a person's past, that's just something that goes along with this territory. It's something that I'm used to, and something I think you should choose an expert who is used to that sort of thing too. Let me talk now, turn our attention specifically to the topic of the day, which is traumatic brain injury. I want to talk about some issues related to brain injury and its assessment. Brain injury is a very serious problem in this country. Most traumatic deaths, most people who are killed in accidents are killed because of the direct effects of brain injuries. It's the most vital organ because the brain controls everything that happens in the human body, including your breathing and your heart. So if your brain is destroyed, you immediately die. There's about 2.5 million emergency room visits every year because of traumatic brain injuries. 280,000 people are hospitalized. 56,000 people die. 90,000 are disabled. More than 1 million people in this country live with chronic TBI-related disability, and it costs us a lot of money. The most common causes of TBI are motor vehicle collisions and assaults. Assaults include, of course, being bashed in the head with a club or a baseball bat or being shot with a firearm. Falls also frequently result in head injuries for the elderly. And young men are especially at risk for head injuries because of their involvement in sports, because of their involvement in risk-taking activities, and frequently because of their involvement with substance abuse. I think I have a video here that might be somewhat illustrative of this fact. Once again in slow motion, just to be sure you get the full effect here. So clearly, this is a young man engaging in some really risky behavior, and he suffers the consequences for it. However, fortunately for him, we see that this in all likelihood is not going to result in a serious head injury for him. He jumps right up. There's no period of loss of consciousness apparent, although this is the kind of injury that could result in a subdural hematoma or intracranial hemorrhage, and 15 minutes from now or 2 hours from now, this young man could well fall over because of a serious intracranial bleeding event. But at least for the moment, he appears to be okay. But this is the sort of thing that is so common with individuals who have, who are of this age and who, get involved in this kind of activity. Let me stop this here and move on. So what's the big deal about the human brain? Well, the human brain is the most complex structure that we're aware of in the entire universe. The human brain has 100 billion neurons, and then another 300 to 500 billion supporting cells. Every one of those 100 billion neurons can contain connections that range in the tens of thousands. So the connections in the brain make it essentially the most complex structure that we know of. There's nothing that we know of in nature that has any more complexity than the human brain. And of course, it controls everything that happens in the human body, every movement that we make, every step that we take, and of course, everything that happens in our mind, all of our feelings, all of our thoughts, everything that happens in terms of our mind happens because of what happens in the brain. And its complexity and its development is what's allowed us to develop into intelligent people who are capable of executive functioning skills. Executive functioning skills refers to the highest order functioning of the human brain, the things that make you and I human. These are things like being able to think and reason through things, being able to feel complex feelings and emotions, being able to get the big picture. The executive functioning skills of the brain refer to its ability to control the mind and its environment. These are things like complex reasoning, if-then thinking, recognizing connections between events, recognizing cause and effect, that if I do this today, I'm likely to suffer that consequence tomorrow. Things like situational awareness, emotional control, impulse control. Our moral judgment is executive functioning, spiritual experiences, all of these fall in the area of executive functioning skills. These are the things that make us human, that set us apart from the animals, and they are the things, they are the functions that are most likely to be impaired by serious brain injuries. These abilities are lost during the course of a brain injury because the brain relies on many different parts of the brain working together in conjunction to create our thoughts and our feelings. Our brain has to put things together in order for us to have the feelings and thoughts that we do. And if the brain becomes disconnected within itself, if different parts of the brain have difficulty communicating with other parts of the brain, then our connectivity and our ability to function at a higher level is damaged. And this is the first thing that tends to go in the course of a traumatic brain injury. And that's why our most sensitive tests for brain injury are tests of executive functioning and memory. These are both functions of the brain that require the entire brain to work together in concert to process information. When the brain can't work together in concert, then we lose the ability to both learn new information and think our way through problems. We talk a little bit about the mechanical causes of traumatic brain injury. These are many. You can have a collision, such as in a motor vehicle accident. You can have a blow to the head, such as a club or a baseball bat. You can have an explosion, which of course is something that we're seeing more and more of with our returning military and military contract personnel over in the Middle East. You can have penetrating injuries, which are injuries that actually affect the brain tissue directly, such as the penetration by a bullet or bone or shrapnel. And then many times, especially very young children, can experience shaking injuries that cause traumatic brain injury. Now let me just mention that these are just a subset of the different mechanisms that can result in a traumatic brain injury. These are the ones we're going to focus on in this talk, but there are many other mechanisms that can result in brain dysfunction. These are things like poisons, neurotoxicity, birth injuries, drowning, asphyxia, electrocution, things like Alzheimer's disease and stroke. All of these affect brain functioning, but they're beyond the scope of this talk today. I'd be happy to talk with any of you about those, but today we're going to focus primarily on traumatic brain injuries, which is the effect of actual trauma to the brain. There are primary injuries and secondary injuries in the course of TBI. One of the primary injuries I just mentioned is penetration by bullets, shrapnel, nails, glass, bone, any kind of object that's moving at a high speed that can punch its way through the skull and enter the brain tissue can cause a penetration injury. And these are the injuries that are most likely to cause focal neurological damage. So if you have a person who can't speak following an injury, or who is blind following an injury, or who has seizures following an injury, it's most likely because of a penetrating injury to the brain. These are the ones that are most likely to result in focal neurological damage of one kind or another. Another kind of injury, primary injury we see with TBI, is contusion. Contusion is just a fancy word for bruise. So a contusion is a bruise to the brain tissue. It's typically caused by impact of the brain against the skull. And here I have my assistant Harlan, who conveniently has the top of his head missing, so I'm going to remove his brain from his skull, and hopefully you can see this okay. As you can see, the inside of the skull is smooth in places, and other places it has notable ridges. These ridges nestle particular areas of the brain, but also if the brain moves around, of course the brain moves against these ridges, and the ridges can cause bruising to the surface of the brain. When this bruising happens, neurons involved in the bruise often become dysfunctional and or die. When those neurons die, the area of function that is subserved by that part of the brain no longer works efficiently or effectively. And so when a person has a bruising of the brain tissue, they have brain damage that can often affect their functioning. These injuries usually occur at certain spots in the brain because of those ridges. There are particular ridges in the frontal part of the brain. The temporal part of the brain also has ridges on the side of it, and occipital poles, which is the back of the brain. All of these, when the brain moves around inside of the skull because of a traumatic experience, because of an impact, the brain impacts the inside of the skull and becomes bruised because it's moving around within the skull. As you think about it, if you're moving at 45 miles an hour in a car and you hit a stationary tree, your body wants to continue moving. However, hopefully your body is restrained by the presence of an airbag and the presence of a seatbelt, and so your body doesn't impact the inside of the car. However, your brain inside your skull is not restrained in any way, so your brain continues to move forward. It strikes the front part of the brain in that impact. It launches backwards, hits the part of the brain, it launches forward again and hits the front part of the brain again. These are called contra-coup injuries because they go back, they're caused by back and forth motion of the brain, and it can result in direct injury to the brain tissue. Often these contusions can be visualized on brain scans such as MRI, especially the higher resolution scans. We can literally see with brain scans the presence of a contusion. Sometimes these contusions result in focal deficits. For example, I mentioned the occipital pole, which is the back of the brain. Many times the occipital pole, when it's damaged or bruised, can result in direct blindness. There's even a very strange condition called Anton syndrome, where an individual has damage to the occipital pole of the brain and they become blind, but because the rest of their brain is intact and doesn't recognize that they're blind, they literally believe that they can continue to see even though their brain is no longer receiving and interpreting visual information. I recently saw a young man about 16 years old who had been injured in a four-wheeler accident. He had had just exactly such an injury. He had Anton syndrome. He was completely blind, but he did not recognize that he was blind. I walked into his room. I said, "Hi, I'm Dr. Walker." I asked him how I'm dressed. He completely made it up, said I was wearing athletic shorts and a T-shirt when, of course, I was wearing a coat and tie. He misidentified the color of everything I was wearing, but in his mind, he was really seeing another person in that room because his brain was generating that information. Very interesting condition caused by contusion injury. Let me talk now, though, about the most important and primary injury we can talk about with TBI, and this is the topic of diffuse axonal injury. Diffuse axonal injury refers to the disruption and destruction of white matter tracts throughout the brain because of torsional forces. Our brains are composed of both gray matter, which is represented as pink in this model, and white matter, which you can see is actually colored white. The white areas of the brain are the connective tissue of the brain, the nerve tracts that allow one part of the brain to communicate with other parts of the brain. Inside this gray portion of the brain, if I could cut this open, you'd also see millions, billions of white matter tracts or nerves that connect one part of the brain to another part of the brain. When the brain is subjected to torsional forces, when the brain becomes twisted by impact or a sudden acceleration or deceleration, those little white matter tracts actually become disrupted and can be destroyed. And that prevents the brain from communicating effectively with itself or transferring information from one part of the brain to the other part of the brain. This, of course, results in decreased efficiency in thinking. It causes problems with amnesia. And at the initial point of the injury, it often causes loss of consciousness. Loss of consciousness in closed head injury is caused by diffuse axonal injury because all of the different axons in the brain become disrupted, some become destroyed by the impact, and the individual literally loses their ability to function as an integral person for a period of time. The loss of consciousness can be very short, it can be just seconds in length, or of course it can last for hours, days, weeks, and months, as we see in what is popularly called coma. We also see diffuse axonal injury resulting in amnesia. Amnesia, of course, means lack of memory. And in order for the brain to form new memories, the brain has to have information available to it to process that information. If your white matter tracts are disrupted in some fashion, if they're not connected with one another, then you literally cannot learn new information, or your learning of new information becomes extremely inefficient. And so you no longer can learn things that happen. You can't remember things that happen from day to day. You can't remember people's names. You can't remember events. You can't remember conversations. Because of this, the length of loss of consciousness and the length of the amnesia are markers of how severe this diffuse axonal injury is. If a person has a very brief loss of consciousness and they're quickly able to remember things again, we can conclude that their diffuse injury in all likelihood was very mild. It's probably the sort of thing that's not going to result in serious problems for them. However, if they have a very extended period of loss of consciousness for hours or days, or if they have amnesia that lasts for days or weeks, then we know that the DAI was very severe with this person and they're likely to go on and experience serious problems. So, DAI is critically important in assessing a traumatic brain injury. Unfortunately, DAI is also very hard to see. It's very poorly visualized on brain scans unless it's very severe. What happens, what we actually see on brain scans, and I'll show you one of these in just a minute, is we see the blood that is produced when the axons are torn. They're tiny little blood vessels that serve the axons. When the axons are torn, the blood vessels are also torn, and we can actually see the presence of blood in the brain tissue on brain scans. Because of the diffuse axonal injury, there are certain things that we can look for in the course of assessing an individual with brain injury. One of the things that we know is that DAI usually affects the parts of the brain that are involved in connectivity, things like the corpus callosum, which is the central white portion of the brain here that connects one hemisphere with the other hemisphere and allows both hemispheres of the brain to talk to itself. The brain stem is this portion of the brain here that connects to the spinal cord. This portion of the brain is involved in things like respiration, heartbeat, and transferring motor and sensory information. And then the long white matter tracts, which were the parts of the brain that I mentioned earlier, deeply embedded in the gray matter that connect the different parts of the brain to one another. So when these parts of the brain, when these axons are disrupted, we see a decrease in exactly these areas. For example, with the brainstem, we see decrease in consciousness, decrease in level of arousal because the brainstem controls our higher order attention and alertness. When we feel sleepy, it's because our brainstem released by trauma. And we're not sure why the brain does this. Perhaps it's because the brain is trying to clean up after an injury and remove all that blood and dead brain tissue. But unfortunately, some of those chemicals also wind up killing good neurons. And so the brain becomes more dysfunctional because of these chemicals. Intracranial hypertension or increased blood pressure in the brain is an issue. One of the worst things that can happen to an individual following a traumatic brain injury is infection. Infection directly damages the brain tissue, and typically damage caused by infection, which we call encephalitis, which involves the brain. Damage caused by encephalitis is usually permanent in nature. So if you have an individual who has an infected brain, who has encephalitis because of a brain injury, in all likelihood they're going to have a very negative outcome. And finally, another secondary injury that occurs in TBI is what's called apoptosis. As we get older, one of the things that happens in our brain just genetically is that some of our cells are programmed to turn off and die. And so as we get older, cells in our brain all throughout our body are dying because of apoptosis. Unfortunately, traumatic brain injury triggers this premature cell death. So our brain thinks it's older than it really is, and many of the cells in the brain begin to die because of this premature programmed cell death. This is one of the factors. Perhaps you're familiar with the current controversy within the NFL and the issues relating to persistent brain injuries in the NFL. One of the things that happens to individuals who have head injury after head injury after head injury is this apoptosis becomes triggered again and again and again. And so we look at a man who is 45 or 50 years old, and his brain scan looks like the brain scan of an 85-year-old man because his brain has shrunk so tremendously from the cell death that has taken place. So let's look at the big picture here. Head trauma results in a panoply of injuries, both primary and secondary. The brain can be directly damaged by things like penetration or bruising or diffuse axonal injury. And then following the direct injury follows a whole series of secondary events occur, such as changes in pressure, changes in neurochemistry, hemorrhages or areas of bleeding within the brain, infection. All of these things result in damage to brain tissue. And damage to brain tissue, of course, results to injury to the patient. If your brain's not working, you're not working. If your brain's not thinking, you're not thinking. If your brain's not feeling, you're not feeling. And so your ability to move, pay attention, communicate, reason, control your behavior, manage your impulses, think ahead, love, whatever it is that you're doing can become seriously impaired by damage to the brain. Damage to the brain results in damage to the human person in general. So let me mention that there are also many confounds when it comes to assessing traumatic brain injury, particularly in the emergency room. An individual comes into the emergency room, for example. Let's say they've spent a night out drinking, they've gotten behind the wheel of a car, and now they've run into a telephone pole. And so they're brought into the emergency room in a stuporous state. That means they don't really understand who they are or what's going on. They're very confused. Their consciousness is not very good. Of course, number one question is, are they stuporous? Are they low in consciousness because of the brain injury, or are they low in consciousness because of their level of intoxication at the time? And so here we see that intoxication can be a real confound in the measurement of how severe a traumatic brain injury is. If we're measuring things like, remember, amnesia, which is a person's ability to form new memories or the lack of it, and we're dealing with a person who's intoxicated, one of the things we know about severe intoxication is that severe intoxication prevents good memory formation. And so it makes it more and more difficult to assess the severity of a traumatic brain injury if a person is intoxicated. There are other neurological conditions, of course, that can look like traumatic brain injury but are not. Things like multiple sclerosis. Multiple sclerosis, like traumatic brain injury, affects primarily the white matter in the brain and causes decrease in connectivity and decrease in efficiency in brain function. But it's not caused by a traumatic event. It's caused by a degenerative process that affects the white matter specifically. Depression can often mimic the impact of a traumatic brain injury. In depression, a person becomes, of course, low in mood, but typically they also have trouble with concentration, attention, energy, focus, wanting to do things. And these are the same kinds of things that we often see after a person who has a significant traumatic brain injury. Bipolar disorder is often a confound because bipolar disorder often both results in traumatic brain injury and can be worsened by a traumatic brain injury. So if you have a patient who has bipolar disorder, they're much more likely to hit their head in the first place because they get involved in unwise and impulsive activity. And then the brain injury itself disinhibits their bipolar condition, so they begin to experience worse and worse bipolar symptoms. I saw a gentleman just last week here in my office who had a pre-existing history of bipolar disorder, and now as a result of his head injury, he has become frankly psychotic. When he gets manic now, used to he would just get very talkative and very hyperactive, Now when he has a manic spell because of his brain injury, he doesn't just get hyperactive and talkative. He completely loses touch with reality and believes things that are completely untrue. So bipolar disorder is a frequent issue. Anxiety, post-traumatic stress disorder, of course, there's a tremendous amount of focus on PTSD in our military members and its concurrence with traumatic brain injury. Many of these soldiers have experienced traumatic events in the military. They've experienced explosions, things that are absolutely terrifying and that can cause PTSD, but also that can cause brain dysfunction. Psychosis, I've already mentioned, intoxication. Chronic pain is a frequent confound if a person's in a lot of pain. And of course, they're not thinking many times very clearly. Maybe they're taking major pain medications that can also affect thinking and behavior. And then, of course, somatoform disorders are a very important rule out with traumatic brain injury because many people want to be taken care of by others. They want others to see them as sick and disabled and want the attention, care, and sympathy from other people. And so they literally develop physical symptoms, develop complaints about their thinking and memory that just aren't true, but in an effort to get the sympathy and support that they need from other people close to them. Well, let's talk about evidence in traumatic brain injury. You are all attorneys, and so I'm sure you're interested in how do you establish, number one, that there has been a traumatic brain injury, and number two, how severe the traumatic brain injury was. There are essentially three streams of evidence here I want to talk about. First is clinical evidence of traumatic brain injury. The second will be imaging evidence, and then finally we'll talk about my area of expertise, which is neuropsychological testing. Clinical evidence. Let's look here at mental status and behavior changes at the time of the injury. We talked earlier about diffuse axonal injury and the fact that changes in a person's consciousness and changes in an individual's memory skills are caused by this diffuse axonal injury. One of the best ways to measure this is what's called the Glasgow Coma Scale. This is a measure that is given by emergency personnel at the time, typically at the scene of the accident or when, upon first arrival into the emergency room. Every doctor who's involved in emergency medicine is trained in giving the Glasgow Coma Scale score. It's simply a way to rate how problematic or how deep a person is unconscious or how much their consciousness is disturbed at the time of assessment. And so the Glasgow Coma Scale score involves best motor response, best eye response, and best verbal response. As you can see here, the scores range from a total of 3 to 15. If a person has 15, then they have essentially no problems in any of these three areas. We can say in all likelihood it was a very mild traumatic brain injury. If their scores are between 9 and 12, where they have difficulty giving these proper responses, then we can classify that head injury as likely a moderate head injury. Or if it's from 3 to 8, we can say that they have a severe head injury, and unfortunately these are the people who are least likely to survive. Loss of consciousness is also a way to measure the severity of the injury. Typically this is rated on a scale from mild, moderate to severe, just like the Glasgow Coma Scale score. If a person is unconscious for less than 30 minutes, they're typically rated as having a mild head injury if there's no other complication like bleeding in the brain. If a person has a loss of consciousness from 30 minutes to a day, 24 hours, then they're rated as having a moderate traumatic brain injury. And if they're unconscious for more than 24 hours, they're classified as having a severe brain injury. Post-traumatic amnesia is another way to clinically measure how severe an injury is. Typically, if a person is able to remember things again the same day that the accident happened, we're going to classify that as a mild injury. If a person has no memory of the entire day of the accident for 24 hours thereafter, then we're getting into the area of a moderate traumatic brain injury. And if a person can't remember things for more than a week, then we see that in all likelihood they have a severe traumatic brain injury. Now, of course, as I mentioned, there are confounding factors to this kind of assessment. Lots of times there are poor records from the accident scene. Sometimes accidents happen and there's nobody there to witness it. And we don't know how long the patient laid on the ground outside their car before somebody happened upon them. Sometimes by the time people actually come upon the accident scene, the person is up, walking and talking, and apparently has no problem, but we don't know how long they may have been unconscious. Intoxication is also another factor that I've already mentioned. Many times patients have such a poor memory of the events surrounding the accident itself that they can't report to me exactly what they remember. And sometimes, yes, patients do exaggerate the presence or degree of their injury. They make up being unconscious, or they make up not being able to remember things because later on they've learned that that's important. Neurological assessment is another stream of clinical data. There's no substitute for a good, qualified clinical neurologist, MD neurologist, who has experience in working with traumatic brain injury patients. A good neurologist can assess an individual's neurological function and can identify the likely location and type of the lesion if it is the sort of thing that has resulted in focal damage to the brain. Things that a neurologist would be interested in are things called decerebrate or decorticate posturing. You've probably noticed that some individuals with severe brain injuries have spasticity to their muscles. One of their hands or both of their hands will be curled up, or their legs will be spastic where they can't walk properly. In the early stages of a traumatic brain injury, depending on how severe the injury is, this posturing, this spasticity of the muscles is often seen early on and then resolves over time. But if you have a patient who has this posturing to begin with, you know you have a very serious injury. The neurologist can also assess things like abnormal reflexes, neurological signs, and the neurologists like to do EEGs, which are direct electrical measurements that can show us how the brain is working from an electrical point of view. Keep in mind that the absence of clinical findings do not mean that the person has not had a serious traumatic brain injury. An individual can have a brain injury, a head injury, with no loss of consciousness, no post-traumatic amnesia, no focal neurological signs whatsoever, and still die from it. How is it that that could happen? It happens because I mentioned the blood vessels earlier that can become ripped and torn in the course of an injury. A person can bump their head even in a mild way, could fall, slip and fall, hit the back of their head, hit the front of their head, and go on about their business, and hours later develop a life-threatening hemorrhage to the brain that can rapidly kill them if they don't quickly receive medical treatment. That same hemorrhage can so squash and distort the human brain tissue that they will go on to have permanent injuries and damage because of that hemorrhage. So the absence of clinical findings does not mean there hasn't been a serious injury. Intracranial injuries are also something that we look at carefully in the course of clinical assessment. I mentioned that contusions and hemorrhages are typically things that we can see quickly on CT scans. There are linear, or there are different kinds of skull fractures we look at, and sometimes we can see the diffuse axonal injury on MRI in more severe cases. The problem is most of our closed head injury cases, we can't see anything because the changes happen at the microscopic level. There is this diffuse axonal injury. These axons are twisted and torn, but there's nothing that we can see on a brain scan. We can only ask them about Glasgow Coma Scale score, loss of consciousness, and so forth. Now, another stream of evidence is neuroimaging. That is taking pictures of the person's brain. I'm going to run through this very quickly. Here we have computerized tomography, MRI. Here is a CT scan of the brain. If you want to impress your attorney friends, you can always tell whether it's a CT or an MRI, because in the CT, the bone tissue shows up as white. Here's an individual. You can see these tiny little white spots in the upper portion of the brain here. Those are areas of petechial, what are called petechial hemorrhages. These are areas where the axons have been twisted and disrupted. Here's an MRI of the same kind of injury. We see an area where blood has collected. Here's a very large intracranial hemorrhage in the right frontal portion of a person's brain because of an injury. This is a 66-year-old man. fMRI is another neuroimaging technique where you actually look at brain function and how the brain looks when it's metabolizing glucose. Unfortunately, this is not a technique that we're really able to utilize at this time to detect pathology. Positron emission tomography is another neuroimaging technique that is of uncertain usefulness in head injury unless we really know that a lesion is there and we want to actually measure the impact of the lesion. Here are some examples of PET scans. You can see the holes there in what looks like to be this person's brain. Those are areas of low activity. Here we see The red, which are areas of high activity, blue is areas of low activity. These areas of lower activity suggest that the individual's brain is not as active in those areas, and that can be caused by traumatic brain injury. Diffusion tensor imaging I mentioned earlier. This is a neuroimaging technique that involves actually looking at the white matter tracts in the brain. Here's a picture of the DTI image. This is relatively new technology. It should meet Dalbert standards for being admissible in court because it really relies upon old MRI technology but just used in a different way. I've seen a single case where DTI was addressed by the court and found to be admissible. Finally, let me talk about my area of expertise, and that is neuropsychological testing. In neuropsych testing, we directly test an individual's mental abilities. This relies on two important concepts for the psychologist, what's called standardization and what's called normative data. Standardization means we give the test the same way over and over again to every patient to minimize any variation. And normative data means that we compare the patient's scores to a large group of individuals who have been given the same test. So we know exactly, for example, how a person who is 72 years of age with a 12th grade education is supposed to perform. We know exactly how a person who is 21 years of age and a high school dropout is supposed to perform. Neuropsychological testing relies on research that establishes the links between the test scores and pathology, and it provides objective evidence in the course of litigation about a person's abilities and whether or not there's evidence of some kind of brain dysfunction. And time again, neuropsych evaluation has been found to meet both Dalbert and Frye standards for admissibility. What happens in a neuropsychological evaluation? We test everything that a person's brain does. We give their brain a real good workout. We test sensory motor function, vision, hearing, speech, how well they can smell things, how well they can hear things, attention, concentration, language skills, naming pictures, memory, visual spatial skills, and of course, the ever important executive functioning. Neuropsychological testing also typically involves measures of a person's personality, emotions, and behavior because these are also produced by the brain and hence are affected by the presence of some kind of brain dysfunction. Everybody always wants to look at what a neuropsychological test is like, so I'm going to share a few examples here with you. Here's a test called the picture arrangement subtest. It measures planning and understanding of cause and effect in social relationships. Here we see a cartoon. I think this is Linus and Snoopy. As you can see, though the squares or the panels have been mixed up, they're out of order. And here the patient is asked to put them in the right order so they will tell a story that makes sense. This gets at a person's planning ability and ability to think through things. Matrix reasoning is another task of executive functioning skills that we give. These involve visual analogies. Here we see the analogy square, A, Z, 1, and then the blank square. What goes in there? Of course, the correct answer is 9. And then another test that's kind of fun is a test called the Stroop test. This is a measure of a person's ability to inhibit responses. And so I'm going to let each of you try this test out for yourself here just a minute. I'm going to move to this slide. Please ignore the box on the screen and just look at the colored X's. I want you to look at the colored X's for a moment and just, if you will, say the colors out loud quickly to yourself as fast as you can. Just go down from side to side, so it would be red, blue, blue, green, yellow, red, green, yellow, and so forth. So do that for me just as quickly as you can. I'll give you just a moment to try that out. Okay, now we're going to do something a little different. This time I'd like you to do the same thing as you did before. Simply say the color of the type. Do not read what the word says, but say the color of the type. So for example, the first item here will be not blue but red. So very quickly say red, green, yellow, blue, and so forth as quickly as you can. As you can see, that's a much harder task than simply naming the colors of the type when there's competing information. What your brain here wants to do is your brain wants to read what the word says. Your brain doesn't want to look at the color. It wants to read the word instead. And so this is what's called an over-learned response. We've all been reading things ever since our fourth or fifth year, and so our brain automatically wants to do this. If we force our brain to do something out of the ordinary, it takes a lot of work for the brain to do that, and brain injuries can affect the efficiency of this process. Let me just mention a few things about neuropsychological testing. Neuropsychological evaluation supplements, but it does not replace the clinical and neuroimaging data that we've already talked about. It simply offers another way to identify injuries, sometimes that are not readily visible on brain scans. It offers another way to measure how badly a person might be impaired that can't be measured by other medical tests alone. It allows us to measure the progression of the disease. In traumatic brain injury, we expect a person to get better over time. And of course, it permits us to provide scientific validation that the condition is actually there. But the neuropsychological testing is never a substitute. It never replaces the clinical data and the neuroimaging data. The neuropsychologist's task is to put all the information together in a way that makes sense. The neuropsychological test data is only one type of data that's considered. And so we consider all these other sources of data, the clinical findings, things like Glasgow Coma Scale score, post-traumatic amnesia, loss of consciousness, neuroimaging results, medical history, other conditions that could affect this particular symptom complaint, occupational functioning, how they did in school, and especially direct observations of behavior, which is critical. The qualified, skilled neuropsychologist can recognize characteristics in a person's presentation just in the examination room that can support or detract from the diagnosis of traumatic brain injury. The neuropsychologist also usually collects collateral data, such as talking to a family member or an employer if there's an occupational question about how this person is doing. And then the neuropsychologist, my job then is to weave all this information into a coherent whole that makes sense, that answers the question of, did this person have a severe traumatic brain injury? How severe was it? What's the information that's consistent with that? What's the information that detracts from that? What's likely to happen to this person in the future? What's the course of their illness likely to be like? Now, there's some significant limitations I need to mention when it comes to neuropsychological testing. Our tests, unfortunately, are relatively insensitive to many kinds of brain injury. So the neuropsychologist sometimes has to rely upon clinical data or neuroimaging data because our tests sometimes are not sensitive to detect the very subtle variations that we expect following a traumatic brain injury. And I'm going to show you a slide related to that here in just a moment. Deficits, of course, are always inferred. Simply because a person gets a low score on a test does not mean they have the low score because of a brain injury. They may have a low score because maybe they've taken too many pain medications that morning. Maybe because they are having a really bad day and didn't get a good night of rest the night before. Maybe they're not trying very hard. So these are limitations to testing. We also have to consider a person's pre-morbid ability. For example, we would expect a person who's worked as a laborer all his life, picking fruit in Florida, to score very differently at 54 years of age than we would expect, you know, say a law professor at the University of Chicago School of Law. We would expect those persons to have radically different neuropsychological test profiles, even though they're the same age, because they have a different educational history, they have a different occupational history. So we have to consider who we're dealing with and make our calculations based upon their likely history. Effort, of course, is a huge factor, and I'm going to show you another slide in a moment showing how important it is that we get a good effort from a patient during the course of an evaluation. If a person doesn't try hard, many times their neuropsychological test results are of very little use to us whatsoever. Confounding factors I've already mentioned. Another problem with neuropsychological testing is absolutely everyone has deficits. If I gave 100 people a set of neuropsychological tests, almost every one of that 100 people will fail at least one of those 30 or 40 tests that I give them. That happens just by chance alone because we're all good at some things, we're all poor at other things, and so everyone has deficits. Simply because you see a deficit in a test does not mean the person is brain damaged. our tests are often not the most ecologically valid. I mean, how many times have you been asked, for example, to learn a list of 10 words after hearing them 5 times? It's not the sort of thing we're often asked to do in the course of our day-to-day life. Yet that's the kind of thing that a neuropsychologist does during evaluation. So sometimes it's difficult to connect what the test has measured to actual everyday abilities. And of course, coaching is a problem. There are some clever people out there who are able to coach patients to try to get the results that they want. Unfortunately, this is a serious problem. In fact, there's been some research that shows that even young children can fool experienced neuropsychologists if they're adequately coached about how to perform on testing. Here's a very important slide that I show to all of my students. This is a critical piece of information as you consider neuropsychological evaluation. Here's the impact of malingering on test scores. The numbers that you see here on your screen are what are called size of effect scores. So a 1.0 on the scale is an entire standard deviation. In statistics, that's a huge amount of variation. That's the difference between being perfectly normal and being below average. So if a person has a difference here of 1 standard deviation, it means that they have a tremendous decrement or a tremendous decrease in their test scores. Here we'll see individuals in the first column, mild closed head injury, who are not malingering. We see that they have a negative 0.12. This is essentially an insignificant score. We wouldn't expect a person with a mild closed head injury to have any significant permanent deficits on neuropsychological testing. This is the kind of difference that we would expect. However, when we have someone who's had a mild injury and they fail malingering tests, they tend to score 1 1/3 standard deviations below the mean as compared to other patients. This is a tremendous effect. This is the difference between a 100 IQ, for example, and an IQ of 78 or 79 or 80, a tremendous change in their functioning. Same thing with severe closed head injury. Here we see a more measurable response. If a person has severe closed head injury, we see a change of about 1/3 of a standard deviation in their test scores. If they're faking brain injury, though, we see a much greater impact. And the same thing is true for general neurological disorders other than brain injury. Effort has a huge impact upon function. Here's another slide that reflects the relative insensitivity of neuropsychological testing. These are IQs and memory quotients. These are scores with an expected mean of 100 and a standard deviation of 15. So anything between 85 and 100 would be considered average. Here we have traumatic brain injury patients that are scoring 87 or in the low average range. So they don't even score in the clearly impaired range on such an important measure as full-scale IQ. Certainly below average, certainly below 100, but not down in the very severely impaired level. In fact, the only disorder here that we can see that we can reliably identify with neuropsychological testing alone is Alzheimer's disease, where Alzheimer's patients get memory quotients of 60. In conclusion, the assessment of traumatic brain injury is an incredibly complex process. There's no simple assessment of something of this nature. The assessment of traumatic brain injury requires careful weighing of many different types and classes of data, things like the characteristics of the injury, imaging information, observation, neuropsychological test data, collateral information. The neuropsychologist's job is to weave all of that information into a set of opinions and conclusions that make sense. Each type of data has its own utility and drawbacks. If you, for example, have neuroimaging data that supports the presence of a serious injury, fantastic. You have something that you can visibly see, but so many injuries are not detected by neuroimaging. Other kinds of information, as we've talked about, has its own drawbacks. The neuropsychologist has to examine competing diagnoses and rule out different conditions that could result in the same kind of test data. The neuropsychologist who does have a background in traumatic brain injury possesses a uniquely well-suited set of tools and skills to assess the traumatic brain injury patient. And this area, this field of endeavor, is something that's particularly challenging, full of landmines, and I wish you the best in your work in this area. Thank you. I appreciate the opportunity to talking to you today. I'm going to take an opportunity now to go over some questions. The first question I have here is, defense independent examination was done. The examiner failed to look at raw data as reported by the plaintiff's expert before writing his report. What are your thoughts on that? As a matter of course, I always ask for the raw data from previous evaluations. Typically, if you're dealing with an experienced neuropsychologist, it's not a problem to get that raw data communicated directly to the other neuropsychologists. We neuropsychologists are very reluctant to share that information with non-psychologists. But there's almost never a problem with one neuropsychologist sharing information with another with the given release. It's important to do that in order to determine the basis of the conclusions. If you don't look at the actual raw data, you can't see the basis of the other individual's conclusions to determine how accurate they are. Now, this is an issue that may have been mitigated in this case by the fact that perhaps the neuropsychologists, as many do, put much of the raw data in their report, so it may not be a critical factor. But if no raw data is in the report and the test data, if the opinions in the matter hinged upon the presence or absence of this data, of course it can be a critical issue. Let me turn to another question here. Someone asked if it's possible to get a copy of this presentation. I'll be happy to make that available. Michael, who introduced me earlier, will be able to transmit that to you. Another question is, how often are you asked to or do you rule out traumatic brain injury? I'm not sure exactly what this question is getting at. It's a question that, of course, I'm often asked to do in many cases where an individual will be referred to me. They perhaps had a bump on their head, they've been involved in an accident, there's some report of loss of consciousness or memory difficulties, and the question comes, has this person suffered a traumatic brain injury and how severe is it? It's something I literally do almost every day in the course of my practice. Maybe the question, though, refers to the appropriateness of a neuropsychologist as opposed to a medical physician making that determination. Many courts in many different states have recognized that neuropsychologists, because of our specialized experience and background in working with TBI patients, are as qualified as physicians to offer opinions about the presence or absence or severity of a traumatic brain injury. If that's what the question is, yes, it's something that I do as a matter of course. I've never had my testimony with regard to that limited or excluded in any fashion by any court. Hopefully that will be continue to be the case. I'm looking at another question here. It appears that this question may be from a perhaps another expert who had a complaint about my recommendations that you choose an expert who is published and who has an academic background. And she made the point that, of course, not all of us have the opportunity to have an academic position or have an opportunity to publish. My suggestion would be, though, that even if you're not involved in an academic medical center setting, if you work in just simply a private practice, you still have the opportunity to collect data. You get to see interesting patients during the course of your work, and those are the kinds of things that can always be written up and shared with a journal. It simply goes to speak to the fact that you're very interested and engaged in what you do and that you're interested in what your peers think about your work. That's the reason I gave that recommendation. Certainly there are lots of fine neuropsychologists out there who have never published a paper. I recognize that fact. But I think that if you have the opportunity to make choices, that typically a publication background indicates at the least that your psychologist has had an opportunity to stay up with the current literature. Looking at another question here. Excellent presentation. Thank you. Here's another question. Malingering versus chronic pain. This is an area that is incredibly fraught with difficulty in assessment. Typically, we have an individual who's been seriously injured in an accident. Maybe they're complaining of back or neck pain or leg pain, and they're also complaining of memory difficulties. So we do a neuropsychological assessment, and let's say we find the presence of memory difficulties. We also recognize that this is a person who has significant chronic pain. Let's say this person also happens to fail some of our malingering tests. The question is, I assume, how likely is it that the patient failed the malingering testing, not because they were trying to provide poor effort or because they were trying to fake, but because they were actually suffering from severe pain at the time? This is something we've been able to look at experimentally. What we've done is we've taken many of the standard malingering tests that we use, and in the experimental setting, we're able to actually subject people to what's essentially severe pain. We call this a cold pressor test, where we put their hand in very cold water for a period of time, then very hot water, and it causes excruciating pain while we're actually administering our neuropsychological test for malingering. Study after study has shown that even under those conditions of a person currently experiencing acute severe pain, they don't tend to fail malingering testing. Typically, people fail malingering testing because they're trying to distort their test results. That's not always the case. There's certainly other reasons for it. Sometimes people can be so severely impaired they can't pass the malingering test, and that's something that I often see in the course of my practice. Sometimes people fail malingering tests because they're psychotic or out of touch with reality, and I think it's possible that a person could perform more poorly than they ought to because of pain. But in general, if we have a person who's consistently failing malingering testing, it's probably because they're not giving the best effort. We have another question here regarding repeated traumatic brain injuries. This question reads, when a person has had a second TBI within a few weeks of an earlier TBI, what should one look at to try to establish that the second TBI was the likely cause of ongoing TBI symptoms? How you would sort through this, I think, is to simply look at the relative severity of the two injuries. Here we would look at things like period of loss of consciousness, post-traumatic amnesia, Glasgow Coma Scale scores, all of those different factors that I mentioned from a clinical perspective earlier. And what we would tend to look at is the more severe of the injuries, the one that had the longer loss of consciousness, the longer period of post-traumatic amnesia, the one that had the lower Glasgow Coma Scale score, whether it happened before or after, is most likely the one that has resulted in any enduring deficits that are present. Again, it's very important here to get someone to look at the emergency room records, the ambulance records, and see exactly how severe each of these injuries were to begin with. Here's a very interesting question. Is a concussion considered to be a TBI if there are no other brain disorders? I think that most neuropsychologists would say that by definition a concussion is a mild traumatic brain injury. A concussion refers to the fact that sometimes you can have an event that involves a blow to the head that doesn't actually result in loss of consciousness or amnesia, but the person may feel dazed, they may feel stupefied, they may have blurred vision, they may have a headache, they may have a whole panoply of problems because they got hit in the head, but it doesn't really rise to the level of a serious traumatic brain injury. I treat those people just like any other mild TBI patient. I think that in all likelihood they're going to have some difficulties as a result of that for the next few hours, if not the next few weeks. But in terms of classifying that person with a moderate or severe traumatic brain injury, of course that's not going to happen. We would not expect a person with simply a concussion, a mild traumatic brain injury, to go on to have any serious problems over time. Here's another question regarding diffusion tensor imaging. The question is, do I notice that attorneys request DTI testing more than coming from a neurologist or neuropsychologist? I'd have to say the answer to that is yes. DTI is not routinely used in a clinical fashion by most neurologists, neuropsychologists, physiatrists, individuals who work with individuals with brain injury. I think the reason for that is because it's still a relatively expensive technique. It's the sort of thing that, you know, a person typically has pretty deep resources to be able to pay for that. It's not routinely done in the course of TBI treatment. However, certainly I think that it's gaining in popularity, and we're going to see more and more of this over time. And the individual who shared that question with me also indicated that he was primarily referring to plaintiff's counsel. To be honest, I have not seen many cases where either plaintiff or defense counsel have asked for DTI. Again, I think that it's not an area that is really well recognized, at least not in this part of the country yet. And it's not something certainly that's routinely done either in the course of clinical treatment or in the course of litigation. Here's a question. We have a slip and fall in a hotel bathroom, no loss of consciousness, broken patella, severe blow to the face, extensive dental injuries. Emergency room, found a cervical sprain, missed the TBI. What about closed head injury may well result in conditions including dementia with behavioral disturbance due to the head trauma? The injury that's described here, unless there are complicating factors, is not the sort of injury that we would expect to result in permanent brain damage. A slip and fall with no loss of consciousness, by definition, would be rated as one of the mildest of the mild traumatic brain injuries. If there's no loss of consciousness, there's no sufficient diffuse axonal injury to cause widespread brain dysfunction, there's no post-traumatic amnesia or anything of that nature. So we would not expect this to be the kind of condition that over time would result in serious problems. Certainly the person may be dazed and confused for a while. They may feel very badly for several days. They may be discombobulated for a week or two, or maybe even at most a month or two. But we wouldn't expect that kind of injury to go on and result in permanent traumatic brain injury. Here's one more question. I'm going to have to close after this. Can a person have a skull fracture in multiple places but not have a brain injury? I think that the answer to that would be most unusual for a person to have several skull fractures and not have some kind of damage to the underlying brain tissue. Now, it is interesting. One of the things that we in this field recognize is that many times a skull fracture can actually help a person survive a traumatic brain injury because the breaking of the skull absorbs so much of the impact that the brain tissue underneath does not then result in the coup contra coup injury that I mentioned earlier. But typically we would expect, especially if a person has several parts of their skull shattered, we would expect some damage to the brain tissue underneath. Whether or not it would be the kind of brain injury that's going to result in lasting changes, we don't know. We'd need neuropsychological evaluation to answer that question. Thank you all again. I appreciate the opportunity of speaking with you today. Let me also share with you a slide that I've been asked to share by the organizers of the webinar today. This contains information. If you'd like to retain an expert, I've worked with the Expert Institute for many years. They're a fabulous group of people who really care about connecting you with the right people to take care of your case and your needs. Don't hesitate to call them if you need any kind of expert consultation in a wide variety of different cases and situations. Thank you all very much.